Hi, this is Dr. Victoria Andarcia. Thank you for joining me again on the Healthful Roots podcast. Today, I'm really excited to introduce our guest, Dr. Erica Bove. She is an OBGYN who is also board certified in reproductive endocrinology, and she has her business called Love and Science Fertility. Yes. Well, welcome. We're so happy to have you, and I would just love you to introduce yourself to our guest.
Thank you so much, Dr. Andarcia. So yes, like you said, I'm a double board certified OBGYN and fertility specialist. Also, we do kind of the reproductive endocrinology stuff that is a little bit sort of like, menopause, puberty, those sorts of things. And as I was getting into practice, I realized that specifically the needs of women were not being addressed. And I was trying in the structure of like regular clinical medicine and really, really struggling to help people make their decisions. So it wasn't, I could explain to them like what their diagnosis was and what their options were. But when it came to really saying like, okay, how do you choose among these options? What's the right thing for you and your values and your individuality and all those things? People were really stuck. And
Mhm.
at that time, I was also engaging in coaching for my own personal reasons. I decided to become a coach through the life coach school. And I thought to myself, like, these coaching tools, this is what my patients need to help them get over that sort of mental struggle of feeling stuck and unable to move forward. And like all the things that come with that, like the overwhelm and the hopelessness and sort of analysis paralysis that we know so well. So then I founded Love and Science, Thriving Through Infertility, about a year ago because I really wanted to create a safe space for women to be able to explore these things with the time needed and the tools to be able to complement traditional REI therapy, but using the coaching framework.
I mean, that's a lot. But I also think it's important how you mentioned the health coaching because I do think that that's something that's missing for a lot of patients. And I can see why you had to start your own thing because there's just not a lot of time in the traditional model to spend that time for coaching with your patients.
Right.
And so today, we're going to chat about fertility, but I mean, this is new. It's a year old. How have you seen that incorporating that coaching has helped your clients?
Yeah. So it's really fascinating. And I just to be clear, I still practice traditional clinical medicine. Like I have a part-time appointment at the University of Vermont, which is great because, without an IVF lab, like there's no way I could keep my skills up and those sorts of things. So I do that still. But when I wear my coaching hat, it is just so gratifying. Like I actually had a female physician come and find me who was like, listen, like I've had a couple miscarriages. I did IVF. I got to euploid embryos. Like I thought that was going to be the thing to fix my problem. But now I've had two transfers. I had another miscarriage and another, non-pregnancy cycle. And I'm starting to really worry that this isn't going to happen for me. And she even said, like, I think my thoughts are blocking this because I'm such in a dark place. Like I really can't see that it's possible that this could work, that I'm worried that it's becoming a self-fulfilling prophecy. So that's why I named my practice Love and Science, because I hold space for my clients with love, right? I help them explore their thoughts and their feelings and how they want to show up, how they're not showing up, all those sorts of things. And what I think about it is like that I hold this loving space so that the science can reach its full potential, if that makes sense. I think there's so much we don't understand about like stress and negative thought patterns and, just sort of, you think about pregnancy, like there has to be receptivity for it to even work. And so many people, because of the process, are so closed off, understandably. But what I help people do is like trust their bodies, trust the process, look for factors for authentic hope. We even do like visualizations of it working so that the science can work. So, individually, this has been super powerful. Like people who have had multiple embryo transfers are finally getting pregnant, which is amazing. Also, similarly, people who have had recurrent losses are not just getting pregnant, but staying pregnant. And now there's this beautiful community of women who support each other. So if there's like something to celebrate, we celebrate. If there's a hard day, we rally around and help people with that too. So it's been really, really beautiful. I had this vision of like, the individual coaching, and I thought the group would supplement for support, but I really had no idea how much the community would be its own asset in terms of people like being stronger together.
Yeah, there's a lot of questions I have for you in that, especially the community aspect, because in my practice, I have found that the experience of like this just fertility journey in general can be very, very isolating. And that's one of the things that I don't have, but I recommend to my patients to find is just women who are going through something similar, because I find that we don't really talk about it enough. So
Right.
that's probably a very healing component of what your services are.
Yeah, and I think you're so right. It is so isolating. And then I think people feel like I'm the only one who feels this way, or I'm the only one in this situation. And then when you can get on a Zoom call, because it's all virtual, and literally see like 8 other women who are just like you going through the same struggles with the same thought processes. Like one woman was like, I can't believe I kicked a hole in the wall. I was so angry. And then like everybody else is like nodding their head, like you totally get it. So it's, there's a lot of camaraderie, there's a lot of support. And I think, one of the pillars of self-compassion is common humanity. It makes sense that people feel this way. And so I think when people can have each other as a mirror, it really helps to reduce a lot of that stigma and shame.
Yeah. And there was another question in there. Because I tell my patients all the time, right? And I don't know that we have directly found how, stress negatively impacts fertility, but just based off of like my own hormonal journey and how like stress was impacting my sex hormones, I can imagine that there is a component of stress and fertility being impacted. We don't really talk about that enough, and I think people are under more stress now than ever before. So what is it, how do you coach women through that? Because like some circumstances can't change, right? Like your job, and especially because I know that you work with a lot of female physicians, you
Mm-hmm.
can't really change certain circumstances. So how would you navigate that stress component?
Yeah, absolutely. So, that is the power of coaching, is that the circumstance can stay the same and there can be sort of a different chain of thoughts and feelings and actions, because what coaching says is that there is a circumstance which is technically neutral, and then there's a thought about that circumstance, and that may or may not be true, but we believe it's true, so it has power. And then that thought induces a feeling in our body, and then from that feeling, then we basically have actions, and even inaction. Sometimes what we don't do is powerful than what we do. And then from that, we get our results in the world. And so if you think about it, like shining a light on thoughts and feelings is super powerful, because 95% of what happens in our subconscious. So when we can actually understand what's going on, then we can say, like, we can challenge the thought, oh, is that actually true? Or, oh, that's what I'm feeling. Oh my goodness. Do I actually want to feel that way? Or do I want to feel a different way about this? And so part of it is like processing feelings and feeling feelings, and then deciding how to show up. And I will say, like, maybe somebody's job doesn't change, but maybe they can draw some boundaries about what they are and aren't willing to do, especially as pertains to like night call and picking up extra shifts for people. I think a lot of what I do is I help people get back their agency, because so often people feel that they're stuck. They're stuck in their work, they're stuck in their life, they're stuck in their fertility journeys, and there's so much power that we have that we just don't tap into. And so that's really what I help people with, is like, yes, I understand. Maybe, you want your job to stay the same, but maybe you can go to 80% for a little bit. Maybe you can find, creative ways to work with your colleagues around this, or, there's all sorts of things I've seen. A lot of my ER doctors have gone to like per diem. And so they're working similar amounts, but they just have a lot more control over like when they actually work and when they don't. And so there's a lot that can be done, I think, outside the box thinking. And that's why I think tuning into the intuition is so important, because a lot of these are like creative solutions that nobody has ever taught us could exist. But I think really tapping into that question, like, what do I truly want? And if fertility, having a child or growing the family is something that's really, really important, then it's like, okay, well, if that's my deepest desire, how do I get there? And that sometimes does mean some modifications to the process.
Yeah. Yeah. That's one of the things and conversations I've had with some of my patients I can think back to is that I think sometimes we want a family and we want to, go down that path, but we haven't really made room for it in the current way that we're living.
Yeah.
So I do agree with you that the per diem thing is a great example of how you make room for something, right? When you have more control of your schedule. But it is hard, and I can relate to that patient when she said that she was in a dark place, because when you're so overwhelmed and you're just like stuck in that pattern, it's hard to see anything else.
It is hard to see. Yeah. And I think sometimes like this whole process is helping people trust themselves, but sometimes you
Hmm.
need a bridge, or you need a guide. Like I know when I was learning to trust myself, I was like, well, maybe I can't trust myself, but I trust my best friend who says XYZ. So I'm going to just sort of lean on her because I believe her and I trust her. And then over time, those sorts of things start to reinforce themselves because I think our brains automatically focus on the negative. We focus on what's not working. We start our support
Yeah.
groups with like, what's the win of the week? Because unless we specifically focus on what's actually working in our lives, it's completely disregarded and we just focus on the negative. So it's, we have to use our brains for us, not against us. And so much of the time, even subconsciously, our brains are working against us.
Hmm. Yeah, that's an important point. And so you mentioned just a tad about your journey. What was it that got you into women's health and, well, to be an OBGYN? Because I read that you wanted to go into psychiatry first.
Yeah, I did. So let's see. So I have always been interested in women's health as such, but I've also really been interested in like what motivates people and love and the human condition and all those things. And so I thought psychiatry was going to be my way in medicine to really like make a difference. And when I was in high school, I was a competitive runner and somewhere along the line developed an eating disorder. So my own sort of hormones were out of whack. And I really had to go through like a recovery process to see my own worth and connect with other women and go through that process. And so I actually went to medical school like I'm going to stamp out eating disorders from the whole world. Like that's my mission in life. And, that was, I mean, I was very ambitious and I did a lot of things like on NPR and I changed the curriculum and made a lot of progress. But once I got to my clinical rotations, I was like, you know what? Like, I like working with my hands. I like solving actionable problems. And in women's health, the way that you're able to make an impact, like, even like GYN oncology, like helping the matriarch of the family get through cancer or helping somebody with a high risk pregnancy or I very specifically remember my reproductive endocrinology and infertility rotation, like 5 p.m. one day, the entire office had cleared out except for like us and the couple being seen. And the woman was like, oh, like I'm glad to be, here, but like my period hasn't come. And so we checked a urine pregnancy test in the office and it was positive and like everybody cheered. And I was like, this is just so meaningful. Like I
Yeah.
can't imagine more meaningful work. So for me, like sort of thinking about what I'm passionate about and where my strengths are, like it just seemed to make sense. And, everyone was surprised. They're like, really? Like, cause like I'm an introvert and maybe I'm not like the most outwardly like aggressive person. I think OBGYN sort of have this rap of being like very strong personalities and because you have to like handle these life and death situations. I'm like, I'll learn it. Like I got this, like no worries. And also my grandfather was an OBGYN. He actually died before I was born. And so I think somehow his spirit has probably influenced this process. But yeah, I decided to go into OBGYN and I thought, if I can make it happen, I'd really like to do, infertility. And thankfully I was able to match at a place where I was able to do the research and meet the mentors. And then I matched. So I went to fellowship for 3 years. And, I think it's one of those things where then you get out and you're like, okay, I've arrived, like here we are. And then you realize there's still so many gaps and the system is so broken. And so it's like, what can I do on an individual level to really make a difference? And so that's really where sort of yes, in my clinic, I give my patients all my attention and I try my very best for them. I look at the literature, all those things. But I really feel like it's largely in the coaching space where I'm able to dedicate the time necessary to go deeper into the issues of like, what does motherhood mean to you? And, especially when issues of like, somebody's own ovaries aren't working anymore and maybe they need to think about other options for family building like donor egg or adoption, like those are tough conversations. And so coming back to people's values, their identity, what really matters to them, what motivates them, what their vision is, maybe there's partner stuff in there as well. That's sort of my zone of genius, is helping people with those sorts of decisions.
Yeah, I can see that that would be a hard conversation to navigate, but it brings us to you're like doing a great segue into
Oh,
my
that's so
questions.
funny.
Yeah. And I wanted to ask you, because, I'm sure a lot of women have this question is, well, I'll ask the first one is like, at what point should women consider freezing their eggs? And is there like an
Mm.
optimal time frame for this?
Sure. So I think the first question is like, is having a family at some point important to you or not? Because if it's not, then the answer is like, don't freeze your eggs and move on with your life. But if part of you hopes to be a mom someday, then I would say think about what is sort of your vision of how many kids you might have. Is it one kid? Is it two kids? Is it five kids? Some people say seven kids. Obviously, those are very different goals. And so my general sort of rule of thumb is if somebody doesn't think they're going to have kids biologically by the time that they're 35, it probably makes sense to freeze eggs. Now, there's cost benefit analyses in literature which say that number is maybe closer to 37, 38, but I don't like waiting that long because the mid to late 30s are not kind to us as women. Some people do great at 37, 38, but other people really suffer with egg quality at that time. And so, that's what I say is like, if you think that you want a family and you don't think it's going to happen by the age of 35, whether it's medical training or a lack of meeting a partner or any of those sorts of things, then let's have that conversation. And so there's different, thankfully, like even in my fellowship, they reversed this from being experimental to now this is like planned egg freezing. Like it's definitely more mainstream than it was. I've seen that in my career. But there is a cost to it and it takes about 2 weeks to do and some insurances don't cover it. And then there's storage fees. And so it's, I always say like, it's okay not to do it, but I see so many people who have serious regret about not doing it that I think it's at least worth a conversation.
Okay. Yeah. Um, and then the other question, and you kind of touched on it a little bit. I know like we are all very familiar with IVF because we're talking a lot about it more on like social media and other avenues. Our friends are doing it. Um, when should you consider that? And what are the other fertility treatment options?
Sure. I usually don't go right to IVF just because, what IVF is it's taking 2 weeks. We go through groups of eggs every month, not just one at a time. And I know you know this, but just for your listeners who
Yeah.
may not know this. So say there's 5 eggs in the group or 10 or 15 or 20. Those eggs are all lost every single month, no matter what we're doing, whether we're on birth control or pregnant or breastfeeding or just ovulating. It's kind of like a pyramid scheme where there's one dominant follicle at the top and then the others are kind of subordinate. And so what IVF does is it basically captures the cohort of eggs that otherwise would have gone away and it makes several co-dominant follicles such that you might be able to freeze 5, 10, 15, 20 eggs in a cycle, not stealing eggs from the future, but basically freezing eggs at the current age. If somebody's 32, those eggs are not going to age with that person. They're going to stay 32-year-old eggs, which is fantastic. So it takes about 2 weeks to do. It's, people giving themselves injections to stimulate the ovaries to do this, coming in about every 2 to 3 days for blood work and ultrasounds, and then, adjusting the dose or not. And then finally that culminates in a procedure, which is done under anesthesia. It's where there's a transvaginal ultrasound probe and a needle that's attached to the probe. And under direct visualization, each follicle is aspirated because in general, each large follicle has a mature egg inside. It's not always a one-to-one correlation, but sort of roughly. And so all those eggs are taken out and then the lab looks under the microscope because these are microscopic. And of the mature eggs, because mature means potentially able to be fertilized by sperm someday, those are frozen for later use. And so, that's sort of the process. Now, say somebody decides that they want to do IVF to have a baby in that same cycle. That's when, before the eggs are frozen, they're actually fertilized with sperm, either partner sperm or donor sperm. And then those embryos are grown out to a certain point, either for a fresh embryo transfer in that same cycle. Sometimes people decide to freeze all the embryos ahead of time, either for fertility preservation or genetic testing of embryos. There's various things that people can do. But in vitro fertilization is the process of, stimulating the woman's body for about 2 weeks, doing the egg retrieval in a lab setting with anesthesia, and then fertilizing those eggs in the lab, creating embryos, and then transferring or freezing those embryos. Now, I usually don't jump right to IVF just because, what we talked about, it's not entirely without risk. There's a procedural risk, a very small risk of bleeding, infection, injury to structures, ovarian hyperstimulation syndrome, where somebody kind of gets all this fluid in their abdomen. It's there if we need it, but it's usually not my first step if somebody comes to see me with infertility. So what do we do? The first visit, we take a thorough history because that really matters. Physical exam. We usually order some testing like egg stuff, sperm stuff, fallopian tube and uterus stuff, preconception stuff. And then we meet again. And I'm always trying to find a diagnosis. So if somebody's just not ovulating, that's usually a pretty easy problem to fix. Just give them a pill to help them ovulate. If somebody has endometriosis, then we can sort of talk about options. If somebody just has slightly suboptimal sperm, then that's pretty easy too. We can usually concentrate the sperm, put the sperm beyond the cervix into the uterus. That's called an intrauterine insemination. and we can do that. So there's a lot of like sort of low tech, non-invasive things that we can do, either using pills to help somebody ovulate, using pills or injections to help somebody ovulate like 2 or 3 eggs in a given month, getting the sperm beyond the cervix. Like that's usually where I like to start if I, you know, if I can, if there's time. I
Yeah.
mean, if somebody sees me at the age of 40 and they're like, hey, I want 2 kids, I'm like, okay, we should really talk about going right to IVF. But usually there's like this stair-step approach. And unless somebody's tubes are completely blocked or there's like such severe male factor that I don't think the sperm are going to work outside of IVF, usually we try one of those other options first.
Okay. Yeah. I mean, I think that it's great. I also believe that IVF as a first option is a little aggressive,
Yeah,
especially if you've never really, tried any other treatments.
same.
But as far as the labs, are there any nutritional labs that you get, or
It's a great
any
question.
vitamins or any things that you're
Yeah.
testing?
So I take a holistic approach, and actually like sometimes I refer somebody to, and I, sort of work hand in hand with my obesity medicine colleagues because they do such a great job at helping people optimize their weight, which sometimes goes along with polycystic ovarian syndrome and such. And so I can't tell you the number of times I've like said like, hey, sounds like weight's been a struggle for you. Sounds like you have PCOS. Like, why don't we invest 3 to 6 months in optimization, and then we'll talk. Like your pregnancy outcomes will be better, your fertility outcomes will be better, all those things. And a lot of times I just get a call and they're like, hey, Dr. Bove, guess what? I guess I don't need you. Like my body's doing what it's supposed to do. So sometimes we're actually out of balance in ourselves, whether it's
Yep.
like, either too little weight or excess weight, or maybe we have all this excessive stress, or maybe we have a chronic disease that's not being managed. Maybe our partner is smoking lots and lots of pot and that has to be addressed. Like there's all these sorts of things that are not medicine that I think we don't give enough credit to. But again, you have to listen, you have to understand the full story and see what's going on. So that's really kind of the first step. And when I check labs, I usually, preconception labs, I want to make sure that people are immune to the things we're supposed to be immune to going into a pregnancy. I check a vitamin D level because there's some data that is associated with better outcomes. There was a recent paper that refuted that, but all things in medicine, they kind of go back and forth. I make sure that my patients are taking something with folic acid in it. CoQ10, I think, is a really wonderful supplement. And I always get a complete blood count because I want to make sure that my patients are not, going to be anemic going into pregnancy, which we know in the second trimester that usually dips. And I always check their blood pressure, make sure that that's good. Sometimes I check cholesterol. And that's, I sort of like, again, this is where like the intuition comes in. Like I usually check a TSH on my patients just because a lot of times thyroid abnormalities can go along with subfertility. But I also just sort of talk to my patients about intuitive eating because, it's interesting. Like I think people might assume that if somebody has infertility that they're like eating all the wrong things and that they just need to change their diet. But I will say like for me and my patients, the opposite is usually true. Usually my patients are doing and my clients are kind of doing everything right, but almost like hyper to the extreme
Yeah.
of like they're so worried that if they have like a muffin with gluten in it like once in a month that they're going to ruin their whole fertility journey. Like there's so much out there that's like if you don't do everything
Yeah.
perfectly, like it's your fault that this didn't work. And so a lot of what I do is actually like helping people trust their bodies. Maybe some people are okay with gluten, other people aren't. Maybe some people are okay with dairy, other people aren't. But really like learning what foods make people feel good and strong, what foods make people feel bloated and not so good. Like I think all those things are really important to try and help people get on the right track.
Yeah, I agree. I laughed a little bit at that because those are the patients that I get too. Like over exercising, like overdoing it with the nutrition. But one of the things that I have noticed is even if you are eating healthy, some of these people still have like nutritional deficiencies. Like their vitamin D might be low, they're
Yeah.
anemic, so I do think that it is important to kind of know where your level's at and then I mean, adjust your diet if there's room for improvement or just like supplement accordingly. Cause I've had women who have to be on like the prenatal and then some more iron because they're just
Yeah,
really anemic.
that's true.
So yeah.
What do
Uh,
you check for your patients out of curiosity?
well, I do the full thyroid panel. I check the B12 folate. Um, I do the full anemia panel on them. Inflammatory markers is another one that I check.
Hmm. Like
And so, yeah,
CRP and yeah,
yeah,
yeah.
CRP. And then, yeah, from that, we kind of go from there. We try to make nutritional changes where we can, or just adding things. Sometimes when I say nutritional changes, it just means that we're just adding certain things, like more flax
Hmm.
seeds or chia seeds, like things that can just like elevate your nutrient profile. But I've seen like stress is like a huge one too, because if you're really stressed, I mean, in functional medicine, you learn that your adrenal glands are going to burn through the B vitamins and the vitamin C, right? So
Mhm.
it's just kind of like taking that into account too. But yeah, that's what I test.
That's amazing. Yeah. And so we're very aligned on that point, and I think it's like, if it's starting to cause additional stress, then it's like, how can we come back to the middle? Because I think that most people know what to do. It's just sort of giving permission to trust the body and trust the process. And I think that's part of it, is like, there's this idea that like, unless I do every single thing perfectly and right, it's not going to work. But I think that becomes counterproductive to a point. So it's
Yeah.
like, how can we actually trust the body and its own inner wisdom? And sometimes that means like changing a treatment plan mid-cycle too. I mean, sometimes these things change over time, but we have to learn to listen to the body. We have to learn to listen, you know, ancestors. Like, it's this interesting thing that like sometimes when a family member dies, like kind of interesting things happen around the time of the fertility process, and so you just have to be open to all of it, I think, for the best possible outcomes.
Well, talking about trusting your body, because this is another question that I get, is how long should you wait before you like seek an opinion on fertility treatments? Because I
Sure.
think a lot of my patients feel that it depends on age, right? Like what the
It
gap
does.
is. So
Yeah. Like under 35 is usually kind of the cutoff where people say, try for up to a year, if not seek, help with a fertility specialist. And then if you're 35 or above, if you've been trying for 6 months and it's not working, see somebody sooner. So that's sort of the line in the sand. But I will say it's not always that black and white. Like, some people clearly are not ovulating. They're not getting a period every month. So it's like, well, like, why wouldn't you see someone sooner? Like, so in those patients, I definitely recommend seeing a fertility specialist, because like, they're going to need help ovulating. If they're ovulating three
right.
times a year, it doesn't make sense to make them like wait the full year, right? Same thing if somebody has like a lot of risk factors for fallopian tube disease. So like, I always think like the sperm have to make their way, through the cervix, into the uterus, into the fallopian tubes, where the egg is released kind of at the end of the fallopian tube. And so if you have a tubal obstruction there, it's kind of like the sperm hit a brick wall, a cement wall, and they're never going to see the egg. And so
Hmm.
if somebody has a history of like a lot of abdominal surgery, or if they have a history of like pelvic inflammatory disease or STIs or endometriosis, like sometimes it doesn't make sense to say like, oh, you have to wait 6 to 12 months. Like, see a specialist, at least get the tubes checked, see if those pipelines are open, so to speak. And if they are, okay, then maybe somebody tries a little longer. But if they're not, then that changes the whole trajectory. So again, it's about listening and sort of understanding what the risk factors are. Also, anytime somebody's anxious, like if you're, wanting 3 children and it's not happening and it's been 5 months, I'm always happy to see somebody. So, I think it just sort of depends on the situation. Because interestingly, if you actually look at the data, even under the age of 35, like most people who are pregnant in that year of trying are pregnant in the first 6 months of trying. There's only like a small percentage that's pregnant between months 6 and 12. So it's like, again, an argument, like we're happy to see people, like, it might just be like, okay, try a little bit longer and see what happens. But at least if people have data about their own bodies, they can start to make some informed choices.
Yeah, and just like the reassurance in itself is medicine, I think.
I think so too. Yeah.
Yeah.
Or like if somebody's
Okay.
mom went through menopause at 41, like maybe their age 35 is not the same as somebody else's age 35. So there's all these different nuances. Like, I think we try to put things in categories because it's simple, but it's really not that simple. And so, that's where like having a good OBGYN can be helpful, because then they can sort of help get people to the right place, like a fertility specialist. But I also think that like I do a lot of talking about trust and advocacy. Like, I don't think those two are mutually exclusive. You can be your own advocate and trust the system at the same time, especially if it's something that you really want.
Yeah. So talking about like trust and intuition, right? What are some things that you think, if someone came to you and they're like, hey, like I'm thinking about, preconception planning, starting a family, and I want to know what I should do. I mean, aside from starting a prenatal, what would your recommendations be like in order to prepare? Because I think a lot of times people are like, oh, I just want to get pregnant, and they get pregnant, but like maybe there could have been more preparation or things that they could have
Sure.
done.
Yeah. Um, like you alluded to before, I think that really just saying, okay, like, even though there's 10 months of pregnancy theoretically, like saying, okay, how is my life right now? Like, am I living my life now that could accommodate like a kid? Or is my life out of balance in a way that this would be like a real life adjustment? And if it's the latter, there are things that people can do to kind of start like sort of decluttering their time, or maybe saying no to certain things, or maybe tuning their attention to sort of other things. And so I think that, being a parent, like there's a sense of identity in being a parent. And so it's sort of shifting from that, like, I am this individual to like, I want to build a family. That sort of identity shift, I think, sort of is important to sort of start to think about. I think having a really good conversation with the primary care doctor or the OBGYN to be like, okay, how is my overall health right now? Is there anything that needs to be optimized? Because we know that, like, I mean, it's a lucky situation if somebody has an uncomplicated pregnancy and delivers that term and the baby's healthy, like healthy mom, healthy baby always. We know that most Americans are, at least overweight, if not in the obese category. And that's something that can often be modified as well, preconception to yield better outcomes. A lot of my patients actually, and this is another thing I didn't mention, I check, for impaired glucose tolerance. And a lot of my patients
Mm-hmm.
are like sort of teetering on the edge of prediabetes. And it's like, well, maybe that's not technically, I call it pre-diabetes.
Yeah.
Because it's like, wait, you're almost there. And we know a lot of the damage happens then, and that's not good for eggs or embryos. So if somebody sort of knows that they want this and that's their health situation, it makes sense to tune the attention to that to try to get into a better space before actually conceiving. So I really think like focusing on like, is my health in the optimal place? Is my partner or are we doing anything, toxic habits that may be fine for like single people or, sort of people who don't have children? I will tell you probably at least a third of my patients, are actively using marijuana. And maybe it's because I practice in Vermont and it's like kind of a free and easy state. But I think, I found that was true actually when I was in Michigan as well, and in New York. So I do think that a lot of people have a lot of anxiety and stress, and they treat that with substances. Again, no judgment. We just got through a pandemic, makes total sense. But like, what can we do holistically to decrease the stress such that those substances aren't necessary? Even alcohol. I mean, we don't necessarily think of alcohol as being a bad actor for fertility. We tell women to kind of maintain a pregnancy diet ahead of time so that, if they do happen to become pregnant, that they're not like drinking, like 2 drinks a day, and they have a new pregnancy. But a lot of people are not, because of the way we live our lives, like jam packed, high achieving, just like sort of on this hamster wheel. A lot of us have accumulated a lot of these unhealthy coping mechanisms. And I really think for best possible outcomes, those need to be unpacked, ideally not during the pregnancy, but preconception.
Right. No, I agree with all of that. I think that's really important. Okay. And this
Medications
is,
too. I mean, later today, I'm interviewing a reproductive psychiatrist. I can't wait for that conversation, because that's
mm,
really the question too. Is like, when somebody is on medications for their mental health, like, when does the risk outweigh the benefit? When does the benefit outweigh the risk? And is there anything else that we can do to modify? Like, most people are not vanilla. Most people are like, well, I know you have depression and it probably makes sense to stay on the meds, but these are the risks. And so that's, I think, because so many of us are so anxious and maybe struggle with depression as well, like that, really, that whole mental health aspect of things, I think it's really important to think about as well. And that's really where I see coaching can have a lot of value. Is it's very
mhm.
action oriented. We know that it reduces stress. We know that it helps people up level every single aspect of their life. And so that is something, even preconception, that we can do to help people all the way through.
Yeah. And I think that is really important because that's one of the things people will come to me with, like, hey, like, what do I do about this medication? Should I stay on it? I don't want to stay on it. But then you worry about what happens if you take them off of it since they, so yeah, that is important. That's very cool. I didn't know reproductive psychiatrist.
Yeah, reproductive
Hmm.
psychiatry. And I mean, there are too few of them. I think that it would be so nice if
Yeah.
we had, but like I've definitely, seen others as well. Like it's a growing field, because I think, perinatal psychiatry, there's a lot, loving and loss, reproducing and loss, those things go hand in hand. And so most women, if you ask them, have actually had a miscarriage, and the
Yeah.
grief that goes along with that. Many women have had multiple miscarriages. And so there's just a lot that nobody talks about, and a lot of, processing of feelings. I actually just read a book recently that was talking about how when we have trapped emotions, like how those sort of blocked emotions can create all sorts of other havoc at other areas of our lives. And so I think it's really about creating a flow state, like being aware of our emotional landscape and then figuring out like how we can navigate that with ease. It's not always easy, right? But it's like, how do
Mm.
we bring awareness to this so that we can be our most authentic selves, so that we're not like resisting these things or avoiding them, that we're like sort of walking the walk and leaving open the space for the best possible outcome.
Yeah, I agree. I'm reading a similar book, When the Body Says No by Gabor Mate.
Oh, cool. No, I
Yeah,
haven't
I
read
just
that
started
one.
it.
This
Okay,
was a
it's
different
pretty
one.
good.
I'll get you the title
Yeah,
later.
no,
I
it's
can picture it. Yeah.
yeah, no, I would love to read it because I'm reading a similar one. Okay, and I have kind of like a selfish question because you work with a lot of female physicians.
Mm.
So, what is it? I know that female physicians in general have a higher rate of infertility than the general population. What is it that you think causes that? I mean, aside from,
Yeah.
maybe they're being exposed to chemicals in the hospital or something, but what else do you think
Yeah.
contributes?
I think it's multifactorial. I think that training is so long. So one of the factors seems to be that like women say they go to medical school and then they have a 7-year residency, especially if they're like 1 in 3 surgeons has infertility, 1 in 4 like sort of physicians in general, and it's 1 in 3 surgeons. It's crazy. And so thinking about it, like, if somebody starts to try to conceive at the age of 37, it's going to be a much different situation than if they're 25, trying to conceive. So part of it is delayed childbearing, which, freezing eggs, it's not an insurance policy, but it can help some of that, in terms of freezing eggs at younger ages. I always though say if, that's just like a surrogate thing. Like if having a family is important to you, we need to like create cultures that make it more accessible for women to have children during training,
Hmm.
because childcare and everything else, it's sort of a big deal. But yes, part of it is the delayed childbearing, and then I think part of it too is the stress. I mean, they've looked at sort of people who work nights, people who work long shifts around their feet. Like those people have higher rates of preterm delivery and such. And so I think the way that we practice as physicians is overall not healthy. It was sort of a much different world. It was like a man's world, right? And then women started going to medical school, and obviously women are the ones who bear the children. And I also think that just from a societal perspective, if you look at studies looking at like mental load and such, say somebody has their first kid and they're trying to be like a mom and a surgeon and hold down everything on the floor at home with all the mental labor that entails, that's a very stressful situation. And so I think we have to really look at like work stress, we have to look at work expectations, we have to look at sort of the cultural, and men too, not just women. Like when childcare is sort of insecure, and I lived this for many years. My former spouse is a physician as well, and we had 2 kids under 2 and no family nearby. And it was just like, how do you do that with call schedules and just the demands? I had very thankful to have my 2 children. Like I had one in residency and one in fellowship, and my family really did. I mean, they came out several times to Michigan from Vermont to be able to help for long weekends when we were both on call. Like it was really stressful, but I just look at that, like talk about like an unhealthy situation. Like this is very stressful. I think it's we need to evolve. We need to have more on-site childcare. We need to have all these different things, because it's not just women, it's men too. This is not a women's issue. This is a cultural issue. And if we're going to really say that like the era of medicine is changing, physician heal thyself, like we have to have systems in place that support that.
Oh, I agree. I agree. Especially like during COVID when they were, talking so much about wellness. There was no time or space for wellness during that time. But, the hospital administrators kept talking about it. But yeah, it definitely is a cultural
Yeah.
issue.
And sometimes
Well,
it looks like practicing medicine a little differently. Like I have a 60% appointment at my academic practice, and I have my coaching. For me at this point in my life, my kids are 10 and 12. Like that has really opened up a lot for me to be able to be present to them and to be able to live life. I think it also, like we talked about before, like when you can't change the circumstance, what do you do? But I do think one thing I help my clients with a lot is like setting loving, flexible boundaries. Like if your boss asks you to take on one more research project and you don't have the bandwidth for that, like it's actually okay to say no, or to
mhm.
delegate, or to do things like that. So I think sometimes we think like we're stuck and we just have to keep saying yes for promotion or whatever else. But I really do think that there's a lot that we can do when we tune into like what we actually want, how our bodies are actually doing. If we really want to do something and we have the bandwidth, there's nothing wrong with saying yes, but that yes has to be authentic and the no has to be authentic. But sometimes we have to say no authentically so that our yeses can be authentic as well.
Yeah, which is like a skill, right? You have to learn
It's
how to be
totally a
able.
skill. Totally
Yeah, I
agree.
just want to say that because sometimes I'm still learning. Sometimes I'm like, oh man, I should have said no. But it is learning. I also feel like in residency and in training, there isn't room really to give that no, right? So then you leave residency and you're still kind of like, oh, I need to
Yeah,
do all the things. But then, I mean, as I worked as a hospitalist first, it took me time to say, like, wait, like I'm actually getting burnt out and I just started.
I
So
know.
yeah.
It's tough. I mean, I do remember one time, I mean, our fellowship was like hard, and I remember like there was no ultrasonographer, and like, I mean, there are just many layers. And I remember one time, like, they asked me to take on this research project that would have meant like data entry at night at like 10 p.m. And I started to cry, and I like actually talked to my mentor about it. And I was like, listen, like, this is how my days are structured. Like, there's no extra time. Like, I don't think I can do this. Like, I really want to, but I I don't have the bandwidth for it. And I mean, that was like kind of scary because I was like a fellow and I'd really never said no to like anything like this before. But it was kind of empowering because it was like, you know what? Like, you know, is life going to go on if that research study is not done by me? Like, it actually is. And so I think really sorting out like what are the important things. And the truth is, like, if we're not honest with what we can actually take on, then we really like we do burn out and we do, you know, leave clinical medicine or like whatever else it is. And so I'm like, if sustainability is important to me, you know,
Hmm.
these things have to be sustainable. And like as I was talking with my boss about like what my current job would look like, when we started to look at like, okay, 50%, 60%, 70%, at 70% I started to cry and I was like, okay, well, that's my limit. Like I can't envision a life where I have a 70% appointment. Maybe in the future I will be able to do that, but like that's what I said, like our bodies know. Our
Yeah.
bodies know. And so like I feel like I have the sweet spot right now. That might change, but I think we have to be honest about these things. Like you said, it is harder in training, but I still think we have some room
Hmm.
to ask for help, ask for extra support. Maybe it's like we need another medical assistant because we're doing all the things in the clinic that maybe somebody else who's not a physician can do. I don't know. But I do know that we're never stuck. And I do know that there's a lot of creative solutions that we don't always think about because we think that we're stuck.
I agree. I agree. Well, can you tell our listeners what your services are for anyone who's like
Sure.
looking for that?
Absolutely. So I have a 3-month program called Love and Science Starting to Thrive. And that's for people who are on the fertility journey, who are really struggling. And I created 12 weeks of content, so videos and homework. And then throughout that time, I do 6 one-on-one coaching sessions that are an hour each. Now, for physicians, I have a support group. I do hope to have to extend another support group. There is a waiting list right now for people who are professional women who are non-physicians. So, but every other Friday night we meet and we do, you know, support groups, and we have a WhatsApp chat in the meantime. And I offer tech support in between sessions as well. Now, we know that the fertility journey is often much longer than 3 months. And so when
Hmm.
people, sometimes I've had people like get pregnant during week 8 and then graduate from their OB and then they sort of are their REI and then they sort of go on to their regular OB. So that sort of a thing can exist. But for people who do want to keep working with me, I do offer a month-to-month membership program and people can still come to the support groups. They can still have access to the coaching and all the resources. And just really, my goal is to bridge people to where they become parents in a way that they are whole and intact and supported. And sometimes that takes a little bit longer. And that's the beauty of doing my own thing is I can tailor it to what people need.
Yeah, no, that's great. And I love the community aspect. I really didn't think about how important that was until I was reading it on your website and your services. And I'm like,
Yeah.
that is so smart rather than saying, like, hey, go find a support group to have it, within your circle. So I think that's great. And I want to thank you so much for your time. I mean, I was so excited to talk to you. It was a really interesting conversation. And
Likewise.
I hope that we stay in touch.
Absolutely.
Well, thank you, Dr. Bove.
Thank you.